Good morning, everybody. So, it's my absolute honor to introduce my own colleague, Professor Divyesh Engineer. He is working with me in the Department of Nephrology in IKDRC, and he's one of those silent workers who does all the job without a fuss. And it will be, so this is a very common scenario that disease owners come with different kinds of sepsis, and we are typically in a dilemma whether to accept it or not, how will it pan out in the, after the transplant. So we are eager to listen to you, sir. Please begin.
Thank you, Subho. Good morning, everyone. Today I am going to present regarding the what to do with disease donor with sepsis, pneumonia, and infective endocarditis. So now there is now renewed interest in the non-standard donors like donor with infection. It is mainly because of the shortage of organs. So we are now exploring more and more regarding non-standard donor like donor with ECD, donor with extension of age, donor with infection. That is the main reason is we want to expand the donor pool. So previously we are skeptical regarding such type of donor because there is a potential risk of transmission of infection from such donor to recipient who are immunosuppressed. But now more and more case report and studies have shown this, it is safe if we go by case-to-case selection with care and we give proper directed antibiotic to donor and recipient. In such scenario, we can decrease the risk of transmission of such infection to recipient with acceptable function of the transplanted organs. So it is not unusual to have a bacterial infection in the donor because they are being treated in ICU where there is very high risk of bacterial colonization. There is a multiple use of medical devices like central lines, arterial line, ET tubes, and also the medical and surgical condition of the donors. So all these factors lead to significant increased risk of brain dead donor in the ICUs. Now, but if you go by the studies and if you see the rate of transmission to recipient from such infected donor, in the different studies and series it is very low and variable. It is like from 0 to 1.7% only. So the rate of transmission is very low. So it is mainly because of the difference in the inoculum size of pathogen, difference in the virulence of organism, type of antibiotic used peri-transplant to donor as well as recipient, organ transplanted with some series showing high risk in liver transplant as compared to the kidney transplantation, and of course the type of immunosuppression used. So with these all factors, the risk of transmission from such infected donor to recipient is quite low, variable, it is definite, so we have to be careful. Now, there is no much prospective randomized control trials in this area. So my talk is based on basically 4 guidelines that help us in such difficult scenario. So first is like a European guidelines. It is EDQM guideline. Second is a Spanish consensus document by National Transplant Organization of Spain. Third is by the basically infection disease community practice of AST. And fourth is basically safety of blood tissue and organs from UK guidelines. So these are the like 4 guidelines that help us in for decision making in such type of donors. Now coming first with the disease donor with pneumonia, lung is the most common site of infection in donor because they are constantly exposed to external environment and they are normally colonized, and almost intubation and ventilation is ruled in all disease donor. So there is a significant increased risk of aspiration and pneumonia. The risk varies from 10 to 40% depending on the type of ICU and time spent in ICU. So what is the risk of transfusion if we are using a donor with pneumonia and we are doing multiple solid organ transplants? So there is a definite evidence in the lung transplant. So if we are using donor with pneumonia for lung transplantation, there is a definite risk of transfusion. But what about a non-lung transplant and the donor is having pneumonia? So there is no much literature in this, but I come across one of the series from the Spain where they have demonstrated that when the donor is having pneumonia and they have utilized kidney and liver, then the kidney recipient got the pyelonephritis with the same organism and the liver recipient developed bacteremia from the same organism. So there is a definite risk of transfusion even with the non-lung solid organ transplantation when the donor is having pneumonia. Now coming to the diagnosis of pneumonia in diseased donor, it is very difficult because most of the time there is no fever in the diseased donor once they are brain dead. Imaging is chest X-ray may be normal in the initial part. CT scan is more sensitive, but they are mostly not available or we are not able to do it because of the hemodynamic instability. Many times we don't have cultures, but even if we have a positive endotracheal tube or bowel culture, we don't know whether it is colonization or infection. So diagnosis is very difficult. Now coming to the recommendation, so there are different recommendations. The Spanish recommendation, what they tell is, if there is an acute pneumonia without systemic dissemination, means pneumonia without bacteremia, it is not contraindication for transplantation except the lung transplantation. So all organs except lung can be used if there is no bacteremia and pneumonia. But the donor should receive effective antibiotic therapy, preferably for 48 hours before retrieval of the organ, and patient and donor should be hemodynamically stable. And of course, the recipient should be continued toward the appropriate antibiotic therapy for at least 7 to 14 days. So the main thing is there should be proper treatment of donor and followed by the same treatment of the recipient. Now coming to the European guideline, what they tell is if there is a pneumonia without bacteremia, we can use all organs. There is no timeline of giving antibiotic, like we have to give 48 hours antibiotic to the donor. But in the lung, and even what they tell is even lung can be used after 48 hours of effective antibiotic therapy if the lung function is not impaired. But there is a catch with the MDR organism. So what to do when there is a MDR colonization? So the MDR organism, basically like a carbapenem resistant Klebsiella, carbapenem resistant A. bovani, they are very difficult to treat. So usually in the setting of lung transplant, if the lung is colonized with the MDR organism, it is a relative contraindication. Lung can be used depending on the urgency and what is the post-transplant therapeutic possibility of antibiotics. Other organ can be used properly with careful monitoring of the recipients. Now what to do if there is a definite MDR pulmonary infection? So Spanish guideline and UK guideline tells any MDR infection is a definite contraindication for transplantation, while the American Society of Transplantation and European guideline what tells it can be considered from case to case basis. But of course, if the lung is infected, lung transplant should be avoided, and if there is a MDR bacteremia, then all organs should be avoided because the risk is very high and we have very little data what happens to such recipients. Now coming to the donor with sepsis. Diagnosis of sepsis in brain dead donor is quite difficult because normally there is no fever because of the failure of the hypothalamic temperature regulating center. If there is fever, it is usually before they got declared brain dead, and once they are declared brain dead, the fever is usually not there, and many times they are hypothermic. Hypotension is a rule. Even when there is no sepsis, it is because of mainly the failure of the vasomotor center in the medulla oblongata. So the typical finding that we use for diagnosis of sepsis like hypothermia, hyperthermia and hypotension, they are not valid clinical parameters for diagnosis of septic state in these donors basically. Even the leukocytosis and tachycardia don't help because the brain dead donor may have a SIRs and so it is very confusing. So diagnosis of sepsis in such a brain dead donor mainly depends on positive cultures and imaging finding. But unfortunately, cultures are mostly not available because of the time constraint, and imaging finding don't help. So many times it is very difficult to decide whether the donor who is on vasopressor, whether there is any evidence of sepsis or not, is very difficult to define. So why we are very much afraid of accepting such donor with sepsis? Because most of the time, if there is a definite sepsis, the almost 80-90% of such donor have a bacteremia. So there is a risk of early sepsis and metastatic abscess in the recipients. The real risk is vascular disruption and bleeding and pseudoaneurysm. That is very troublesome, and many times that lead to graft loss. And even when the recipient develops sepsis, then we can even have a graft failure because of sepsis. And many times to manage the sepsis, we make a reduction in immunosuppression, and many times it can precipitate the rejection. So even ultimately this sometimes may also lead to graft failure also. Now coming to what the studies tell. So the first study was an old study from 1992 or to 1996 from Freeman. What they found was there was a nil transfusion of infection from the bacteremic donor. And second study was a recent study where there was 86 kidney transplant from 68 bacteremic donor, and even the organism were like a Staph aureus enterococci, and what they found was there is only 1 out of 83 recipient got infection. So the risk of infection from the bacteremic donor in the studies is very low basically. Now coming to our own data. So we are having active disease donor transplant center. So we try to analyze retrospective analysis of all donors for last 2 years from 2022 to 2023. We have a protocol of sending blood culture of all the donors before retrieval. So many times the reports are not available when we use such kidney. Reports come after 20 or 48 hours. So what we see in the last 2 years, we total do 295 disease donor transplant, and out of that 21 donors were found to have a bacteremia. Out of these 21 donors, we did 39 renal transplantation, so that is almost 13% of the all donors. And what we find was the rate of transfusion was 0%. But we do recipient culture not routinely. Recipient culture was used only when clinically indicated, when the recipient got fever. So there was no routine recipient culture. And the type of organism that we see in the donors, the most common was E. coli, followed by MRSA, Pseudomonas, Burkholderia, Klebsiella. So if you see the report, all these reports become available when we have used the donors. So despite this multiple types of MDR organism, the risk of basically infection is very low. Coming to the recommendation regarding the sepsis, the Spanish recommendation, what they tell is if there is a sepsis or septic shock of unknown origin or suspicion, then it is a contraindication for transplant. So means if we are suspecting sepsis and we don't know organism, then we should not proceed. If the sepsis or septic shock is fungal or tuberculosis, then we should not proceed. Now, if there is a sepsis or septic shock of bacterial origin, what the Spanish guideline tells is if the donor is showing sign of sepsis at the time of retrieval, then we should avoid such donors. But if they are treated then and donor is recovered from the sepsis or septic shock, then we can use such donor. But we have to look for the organ damage, because many times the sepsis lead to many times reversible irreversible organ damage. So such organ damage should be excluded by careful physical examination of the graft and with the help of histopathology. And we have to even see for the persistent focus of infection in the graft. Coming to the American guideline from by EST and European guideline, what they tell is donor with bacteriemia and sepsis may be accepted if donor received targeted antibiotic therapy for 24 to 48 hours. There should be some degree of clinical response in terms of improved WBC count, hemodynamics and effervescence, and the recipient should be treated for 7 to 14 days. In such scenario, donor with bacteriemia and sepsis can be treated. But the catch is we have to assess for the metastatic infection. So it is very difficult. So what we have to do is before retrieval, we have to subject the donor for careful ultrasound examination, if possible CT and MRI, to have any embolic infection. And if there is a focus of infection, should be never transplanted. So if the focus of infection is lung with septic shock, then you should never undergo the lung transplant. And regarding MDR bacteremia, most of the guideline tests, MDR bacteremia is the absolute contraindication for transplantation, because we have very little data regarding this. Coming to endocarditis, there is a definite risk of endocarditis transmission to recipient if the donor is having endocarditis. It is very much well documented when there is a mitral valve endocarditis with MRSA and enterococci. The risk of endocarditis is high, and dissemination of such organism recipient is highest if there is a mitral valve endocarditis, if the vegetation size is more than 1 centimeter and organism is like a Staphylococcus aureus, particularly MRSA. So in such scenario, risk of bacteremia dissemination and risk of transmission to infection to recipient is quite high. Now we have two series. One is initial series from the Spain. What they found was out of in the 3 years, 4 donor has basically endocarditis, and they did 7 transplant, 5 kidney transplant, 2 liver transplant, and what they found was there was a 0% risk of transmission with good graft function. But that protocol was very stringent. So what they did was they always excluded metastatic infection with a pre-donation liver, kidney, pancreas, ultrasound, CT or MRI, and they always excluded MDR bacteria. So and this is followed by careful examination of graft after retrieval and after transplantation, careful monitoring and treatment of recipient was done. So with this stringent protocol, their risk for infection or transmission was almost 0%. Coming to the big series from the UK, so they have 88 transplant from 42 donors with organisms like Staph aureus and Streptococci. There is no risk of infection transmission in this series, and the function was also good. So they are very encouraging outcome of this UK studies. Now coming to the recommendation, what to do regarding donor with infective endocarditis. So if the patient is having endocarditis, heart donation is contraindication. Other organs can be accepted if patient received proper antibiotic therapy prior to donation, minimum 48 hours, and they tested negative for bacteremia, and there is no evidence of embolic phenomena that have damaged the organ. So if the donor meets all these criteria, and if we have a proper antibiotic that can be given to recipient, then we can accept organ for donor with infective endocarditis. So now to coming to the conclusion, the key step while we deal with this infective donor with infection is there should be prompt transmission of information from donor to recipient center, because many times the retrieval center is somewhat different and recipient center is somewhat different, and sometimes the reports, sometimes culture reports comes late. So there should be a system for prompt transmission of this information. Then recipient center should always assess whether the benefit of risk outweigh the risk of disease transmission. Decision is very easy in case of life-saving transplant like a liver, heart and lung transplant, but calculated decision should be taken with the kidney transplantation. Informed consent should be taken from the recipient, and there should be definite treatment plan even before proceeding for transplant. And right now we are lacking this like a biovigilance, but I think the Roto-Soto can go ahead with the biovigilance, so they can be a central authority to collect the data from the donor retrieval center and disseminate such important information to all recipient center. So even if the cultures are detected positive late, prompt treatment can be given to recipient and with good outcomes. Thank you.